Good afternoon. Welcome to our PCORI-sponsored webinar series focusing on metastatic cancer patient outcomes. Today's focus is metastatic prostate cancer. This webinar series is a direct result of input from patients, caregivers, clinicians, researchers, and all stakeholders invested in metastatic cancer research. Today's webinar objectives are to provide the patient-family perspective about prostate cancer, describe cancer and treatment-related symptoms, discuss metastatic cancer-related quality of life concerns, and explain metastasis and priorities in metastasis research. We have a panel of 4 experts who will each present, and then we will open up for questions and discussion. Sorry, I'm trying to forward my slides. Today's panel presenters are Mr. Broderick Crawford, Dr. Sally Maliski, Dr. Ben Tepley, and Dr. Leah Cook. Mr. Broderick Crawford is the Executive Director of the NBC Community Development Corporation and a consummate community volunteer dedicated to improving the lives of those who are less fortunate. His advocacy journey began 10 years ago as a caregiver for his father, who is a prostate cancer survivor. Over the last decade, Mr. Crawford has worked with researchers, clinicians, health systems, and public health departments to give voice to minorities who are underrepresented in healthcare research. Mr. Crawford serves on numerous community boards in Wyandotte County and is also on several committees related to health research, currently serving as the president of the Missouri Prostate Coalition. In November 2018, Mr. Crawford was one of 4 individuals to receive the Aetna Community Health Leadership Award. With more than 30 years of experience, Dr. Sally Maliski is Dean of the University of Kansas School of Nursing. She holds an administrative appointment as Associate Director for Population Health and Disparities with the University of Kansas Cancer Center and serves on the Board of Directors for the University of Health System and University of Kansas Research Institute. Dean Maliski's research focus includes quality of life and cancer treatment-related symptom management among underserved populations. She has a strong commitment to reducing cancer health disparities and understanding the factors underlying such disparities via interdisciplinary teamwork. Hospice, oncology, and free clinic primary care highlight her clinical interest. Dr. Ben Tepley did his training in internal medicine at the University of Michigan in Ann Arbor, and then his fellowship training in medical oncology at Johns Hopkins University in Baltimore, Maryland. He is currently an assistant professor of medicine at the University of Nebraska Medical Center in the Department of Hematology and Oncology. His clinical expertise is in urologic cancers, including prostate cancer. He also is actively engaged in clinical and translational research in prostate cancer, focusing on novel hormonal approaches, biomarkers, and optimizing use of approved therapies. Dr. Leah Cook began her career as a cancer researcher in 2004 as a summer research student at the University of Alabama, Birmingham, where she studied methods of dietary chemoprevention of prostate cancer. She received her pre-doctoral training in molecular and cellular pathology under the mentorship of Danny Welch at UAB, where she focused her research efforts on breast cancer metastasis, and then received postdoctoral training at Moffitt Cancer Center with Connor Lynch, studying mechanisms associated with progression of bone metastatic prostate cancer. Dr. Cook joined the University of Nebraska Medical Center Department of Pathology and Microbiology and the Buffett Cancer Center, where a major focus of her lab involves identifying novel immune cell interactions that contribute to prostate cancer growth and bone and cancer-induced bone disease. So without further ado, please welcome Mr. Broderick Crawford.
Hello, everyone, and thank you for joining us in today's webinar. Let me say that I am certainly honored to be amongst the expert panel and the panelists that you will listen to on today. My story, again, as was mentioned, is basically as a co-survivor with my dad. And as you can see, the first picture on the screen here, it is no question about what I would look like some 30 years from now. So that is a picture of myself and my dad at a recent holiday gathering at his home. Again, as stated earlier, my dad is actually a 13-year now prostate cancer survivor. And what's really interesting is he falls into some of the challenges that we have with African-American men. Because he now has Medicare and a supplement, PSA testing wasn't done unless requested on my dad, and he wasn't diagnosed until he was 79 years old. As you look at him today, he is 89 years young and is vibrant and doing well. However, my dad has many other complications which limited the type of therapy that he could have once he was diagnosed. Dad, as you look there, is visually impaired. He's in a wheelchair. He has a defibrillator. He has a tube in his bladder. He is unable to walk. He has sleep apnea. But if he were to roll into this webinar right now, you would not see any of that. And that's a testament to what he feels that has carried him with which is his faith and his family. A little bit about prostate cancer. According to the American Cancer Society, there'll be about 174,650 new cases this year. About 31,620 deaths are expected this year. Often there are no symptoms, particularly when it's early in disease. Prostate cancer is the most common form of cancer, second to skin cancer. And so, again, it is something that is prevalent in our communities. One thing that's also interesting is that 1 in 9 American men will be diagnosed with prostate cancer, but yet 1 in 6 African-American men. And the challenge, which is why I am so passionate about speaking with you today, is because African-American men are dually disadvantaged because they are less likely to seek just regular medical care, then also having biological differences, which I'm sure you'll hear from the presenters, which make them more prone to prostate cancer and the prostate cancers that are often detected in men are more aggressive. So the fact that we have African-American men who are less likely to get tested, less likely to get care, that puts them in a position to have or a greater need to get tested and more frequently. Of course, as I mentioned, my dad is a prostate cancer survivor. So myself, it is for me to get tested. The second slide there, the young man all the way on the right is my oldest son. The one there to the right in the middle is my youngest son, and then my nephew, and then my nephew's son. And so here you have 4 generations as you look in our family, but yet the possibility of each of the 4 of us getting cancer is high. And so one of the things that I have tried to advocate is checking history. After getting more involved with the different groups, the National Association for Prostate Cancer Coalition, also here locally, the Prostate Network, it has become very obvious to me that we have to engage African Americans earlier in the conversation. My dad has 2 uncles that have had prostate cancer and died from complications. My dad has had 2 cousins who have died, and none of this was discussed amongst the family. Now, having this information historically, we now know that genetically we have something in our genes that causes us to be more likely or more prone to be diagnosed with prostate cancer. So if I were to leave you with any takeaway, is that with African American men, because they're less likely to go and seek care, because they are more prevalent, 2/3 more prevalent in being diagnosed, and because it is probably more prevalent in the history of these African American men's families, it is important for African men to be tested more early. Now, certainly, I have good friends of mine that don't necessarily care for the DRE, which is the digital rectal exam. I tease them in that I say that's why I chose a female doctor, because she has smaller fingers. And so, but we have to do what is necessary for us to make sure that we are being diagnosed at an earlier stage. Certainly using the PSA test is another tool. But one of the things that when I talk with specifically African-American men is that don't use that as the only tool. There are many other tools that you can use, certainly talking with your urologist, talking with your primary care physician, talking with others. We have several peer groups that bring men together who have been diagnosed and are survivors of prostate cancer. Again, like the two groups I mentioned earlier, NASPCC and the Prostate Network, that men can go to get other information. And so sometimes talking with peers will get you better information than talking, I won't say better, it'll get you additional information that you may or may not receive from your physician. When you have individuals who have the lived experience, that lived experience matters when it comes to a person being more receptive to getting the necessary tests that have to be done. And then finally, and I talk to wives, I talk to sisters, I talk to moms. Oftentimes, men will listen to their wives, their daughters. I have one instance where this daughter stayed on her dad, and because she stayed on him, it actually saved his life. It stopped his particular cancer from spreading to other areas of his body. I also have a young man who was actually in my church who, while he was living, gave his testimony that his particular cancer it started in his prostate, went to his colon, went to his gallbladder, and his pancreas. And it all started with prostate cancer because once he was diagnosed, he didn't do anything. And so while he was living, even when he was diagnosed, he was, once it began to spread and metastasize, they didn't give him but 6 months to live. Well, he actually lived an additional 3 years. And again, he gives that to his faith and to his family. But again, it just exemplifies the need for, once diagnosing is done, once it is very treatable when detected, but it's very, very crucially important for men to be detected early. Thank you for allowing me to speak with you today. I look forward to your questions.
Thank you, Broderick, for sharing your perspective as a co-survivor. Now we're going to turn it over to Dr. Maliski to talk about androgen therapy.
Good afternoon. It is truly a pleasure to be here with you. Can you see my screen?
No, not yet. There you go. Now we can see. Okay, thank you.
Well, thank you so much, and thank you for bearing with me on the technology. So with this, we're going to talk a little bit about androgen deprivation therapy and the relationship of hormones to prostate cancer. As you just heard from Broderick, African-American men certainly are at higher risk. And with that, we do think about, when we talk about when androgen deprivation therapy is used. But at a very basic level, androgen deprivation therapy decreases testosterone levels to almost castrate levels. And with that rapid drop of testosterone in a man's body, we do get a variety of effects. However, androgen deprivation therapy has very good, or has improved survival for men considerably. And it's a therapy that many men may be on for a considerable period of time, which is why we are concerned about it, and as we'll talk about in a little bit, we'll be thinking about the side effects that go with it. But androgen deprivation therapy, to kind of look at when it is used, first of all, can be used when a man cannot undergo primary definitive treatment at diagnosis, such as surgery or radiation treatment. It also is used, and think about what Broderick just said, when men are diagnosed with later stage disease that may not be amenable to surgery or radiation alone. We're finding more and more with research that androgen deprivation therapy improves outcomes with radiation therapy. You will see that radiation therapy used in combination with androgen deprivation therapy will be used increasingly. We're seeing some forms of androgen deprivation therapy being used earlier in the treatment trajectory. So with that, we're seeing androgen deprivation therapy, men being on it for even longer periods of time. Also comes into play when after primary treatment, men experience a recurrence, a biochemical recurrence, meaning that their PSA levels start to increase again. And then finally, with the development of metastatic disease that is responsive to androgen deprivation therapy, this will be instituted as a form of treatment, again, that the man can be on for years and increases their survival for an extended period of time. However, as with many treatments, it is not without side effects. And while at one point in time, androgen deprivation therapy was thought to be fairly benign, we have learned over the past several years that there are multiple effects that come with decreasing a man's testosterone and estradiol to near castrate levels. The side effects that we most commonly, or that are commonly associated with androgen deprivation therapy, are hot flashes. Men experience decreased sex drive, known as low libido, erectile dysfunction, loss of lean muscle mass, weight gain, and sometimes gynecomastia, or increase in size of the breasts and discomfort. And as you can well see, some of these effects can be thought of or felt as feminizing. There are other effects of androgen deprivation therapy that are less evident to the person on treatment. We see increased insulin resistance. And what that does is increase the risk of diabetes, of metabolic syndrome. We see dyslipidemia, and with that, we see a switch in the good cholesterol and the bad cholesterol. The bad cholesterol, or LDL, increases, and the good cholesterol, or HDL, decreases, which can increase the risk for heart disease, cardiovascular disease. We see decreased arterial compliance. That means the arteries are less able to stretch, if you will, to accommodate changes in the pressure of blood being pumped. And with that, we can start seeing increased blood pressure. Again, increased risk for cardiovascular disease. We see increased visceral fat deposition, fat around the midsection. We see weight gain. Sometimes men will attribute this to the androgen deprivation therapy, sometimes not. Loss of lean muscle mass. And with that, fatigue, We see bone demineralization, which can increase the risk for fracture. We see cognitive changes, as well as with all of this depression, which can be an effect of the treatment of the cancer or of response to the cancer, more likely all put together. So with this, while as we see men on androgen deprivation therapy for longer periods of time, we need to be concerned about quality of life and how do we help men and their partners and their families manage these side effects. So a couple of things that we've done, and one of the studies that our team is working on, is really looking at quality of life and symptom management, and particularly reducing some of the risks that we just talked about that are associated with androgen deprivation therapy. Numerous studies have shown that both nutrition and activity interventions outside of androgen deprivation therapy can decrease the risk for cardiovascular and metabolic disease. So looking at that within the context of androgen deprivation therapy, we have done some pilot work that demonstrated improvements in men's lipid profile while they were on androgen deprivation therapy. We're continuing that work to see with some expansion and modifications of that intervention, can we decrease the visceral fat deposition, improve, or at least not see worsening of lean muscle mass, see improvements or stabilization of blood pressure and cholesterol measures. We do that by combining activity with a physical therapist, nutrition with a dietitian, education and goal setting with a nurse interventionist. We also have found with studies and with prior work talking with men that men are not always aware of the cardiovascular and the metabolic risks of androgen deprivation therapy. There are the visible things that we talked about, the weight gain, the hot flashes, the gynecomastia, loss of sex drive and erectile dysfunction, but there are these other hidden factors that are associated with androgen deprivation therapy that make the education component important in understanding why activity, nutrition, and other lifestyle activities can really benefit their ability to stay healthy while on androgen deprivation therapy. So with that, by combining education about androgen deprivation therapy, its effects, and strategies that can be used to manage those symptoms, including nutrition, activity, and activity being both aerobic and resistance training as being important, particularly for muscle mass and the bone demineralization. Staying cool. Unfortunately, for hot flashes, we have not really gotten a good handle on strategies to manage hot flashes really effectively. Some men have are very bothered, have very severe drenching sweats, others minimally. Probably one of the biggest things is communication. Communication with your providers in terms of the symptoms you're experiencing, what's bothersome, what's worked, what's not worked for you. As Broderick said, talking with others who have experienced who have the lived experience of working with and managing their symptoms. And communication with family members, particularly important with intimate partners in working through and dealing with erectile dysfunction and changes in desire for sex. And then finally, in working with your providers, the use of medications, some medications both for depressive symptoms, lipid management, cholesterol management, cardiovascular management of metabolic syndrome and diabetes, all important in maintaining quality of life and staying strong and healthy while on androgen deprivation therapy. Unfortunately, as you will hear at some point, androgen deprivation therapy will no longer be responded to, and then other forms of treatment will come into play. Okay, thank you very much, and I look forward to your questions at the end.
Thank you, Dr. Maliski. Now we will hear from Dr. Tepley, and he's going to talk about hormone-resistant therapy.
Thank you very much. It's a real pleasure to have a chance to speak with everyone today. And I'll be speaking about management of metastatic hormone-refractory prostate cancer with a specific focus on symptom management in this disease state. And this is the definition of the problem. Metastatic cancers, unfortunately, will inevitably progress despite the androgen deprivation therapy that you were just hearing about. This results in a disease state for prostate cancer that we call hormone refractory or castration-resistant prostate cancer. In layman's terms, this is essentially prostate cancer that has gotten worse despite the androgen deprivation therapy that the patient is receiving. From a standpoint of regulations or clinical trials, there's a more formal definition, which I've also listed here. And going through this is some objective measure of worsening of the cancer, either an increase in the biochemical measure or the BSA or the PSA, new or increased metastasis on a radiographic study, such as a CT scan or bone scan, or worsened symptoms that are attributable to the cancer, all while the patient is receiving this androgen deprivation therapy, which leads to low levels of testosterone as a therapeutic outcome. The reason it's important to specifically identify and come up with treatments for this disease state is that unfortunately, patients that develop castration-resistant prostate cancer are likely to develop symptoms from the cancer. And ultimately, this is a form of prostate cancer that's likely to kill men. And most men that develop castration-resistant prostate cancer will ultimately succumb to this disease. And the prognosis is unfortunately guarded, where the median survival is likely in the range of 2 to 3 years. We just heard a great deal about treatment side effects from androgen deprivation therapy, and introduce management of symptoms in metastatic castration-resistant prostate cancer. I first wanted to go back to exactly what we were just discussing. For patients that are first treated with hormone therapy, typically the major clinical problem we deal with is actually dealing with the treatment side effects, because the cancer is initially very responsive to androgen deprivation therapy. So cancer-related symptoms tend to be a minor consideration for patients that have hormone-sensitive disease. However, when patients develop this hormone-refractory disease, I find that the balance really shifts. So the main clinical problem we often deal with is actually cancer-related symptoms. And so therefore, when patients have this, very frequently we will tolerate more aggressive treatments or treatments that have increased side effects if they're able to relieve these cancer-related symptoms. What are some of these symptoms that are commonly encountered in this disease state? Patients can have constitutional symptoms such as fatigue, loss of weight, just generally not doing their usual activities. Pain is a huge problem for patients that have metastatic castration-resistant prostate cancer. For patients that have a primary tumor in place in the prostate or a local recurrence, problems with urination or obstruction can be significant. And for patients that have metastasis in bone, Complications from these, including bone fractures, can be devastating. When thinking about optimal symptom management for these patients, it's really a combination of several approaches that need to be used. I'll speak about several of these. The first one I want to emphasize, going back to the previous slide about really the main source of problems, is that effective anti-cancer therapy is essential to prevent these cancer-related side effects. Furthermore, therapy that's specifically directed at bones and preventing of complications from bone metastases is essential. And lastly, just general supportive care, as we were hearing about. I'm going to speak for the next several slides about anti-cancer therapy options for this disease state. Here, I've listed several of the FDA-approved drugs that can be used for patients that develop metastatic castration-resistant prostate cancer. These include advanced hormone therapy with the drugs of enzalutamide or abiraterone, chemotherapy with taxane chemotherapeutics of docetaxel or cabazitaxel, immunotherapy with an autologous cellular vaccine called Sipuleucel-T, or radiotherapy with an intravenous radiopharmaceutical called radium-223. Although we've used other medications, and other medications are options for management in these patients, I've chosen specifically to present these because they've all been demonstrated to actually prolong survival in this disease state. As an example about the role of effective anti-cancer therapy with regard to symptom control and quality of life, showing some data here regarding the study of enzalutamide, one of these drugs that's available for treatment in these patients. On the left, you see the results from the phase 3 clinical trial. It was a blinded placebo-controlled trial that led to the FDA approval of enzalutamide before chemotherapy for patients that have metastatic castration-resistant prostate cancer. The primary endpoint here was looking whether this is a treatment that would actually extend survival for these patients, and it did. On the right, I've also demonstrated, presenting here, some of the quality of life measures that were taken during the study. This is just one of these measures that was taken. This is the FACT-P prostate cancer subscale, which is one of the validated instruments to try to attempt to measure quality of life while on these treatments. And as you can see on this figure, the patients that received the enzalutamide had a better chance to maintain their quality of life over the treatment course of the study compared to those get placebo. I think the important point I want to make here is that not only is an effective anti-cancer therapy prolonging life, but it's doing this by preventing these cancer-related symptoms. And so really effective anti-cancer therapy is essential in terms of symptom management for these patients. I've chosen just to present enzalutamide as one of the examples, but the same can be shown for abiraterone and several of the other medications that are possible here. As another example, wanted to show the same thing for the intravenous radiopharmaceutical of radium-223. Where on the left, in the randomized placebo-controlled blinded study, the patients that received radium had an improved survival. But importantly, on the right, the way that it did this is that it prevented patients from having catastrophic skeletal problems, which is such as fractures, significant pain that requires surgery or radiation therapy. And so again, an effective therapy like this is not only prolonging survival, but actually preventing major complications from the cancer. And thinking about options beyond the standard FDA-approved agents for prostate cancer, one of the things that is an option for patients is doing molecular profiling, or identifying exactly why the cancer is progressing, what the underlying genetic drivers are for this. Wanted to make special note of a particular immunotherapy called pembrolizumab. Although it's not specifically approved for prostate cancer, for any cancer that has a certain genetic signature, this is a therapy option. And I displayed here on the right from the publication describing the use of pembrolizumab in a variety of cancers, that up to 2 or 3% of patients with prostate cancer may carry this genetic signature, and this may be an option for them. And furthermore, using this molecular profiling as a way to match patients to clinical trials. Beyond effective anti-cancer therapy, other supportive care is essential in getting the best outcome for patients. This includes multidisciplinary pain management, whether it's medication or interventions. physical therapy to maintain activity, nutrition support, integration of early palliative care, and use of hospice care at the end of life. All of these things are essential in a patient's journey through metastatic castration-resistant prostate cancer. In conclusion, unfortunately, castration-resistant prostate cancer, patients that develop this have a very high risk for symptoms and ultimately death from prostate cancer. Our effective anti-cancer therapy should extend life and improve quality of life. It's essential that in future clinical trials or studying this, that these measures are included. And lastly, multidisciplinary supportive care is essential to get the best outcome for our patients. Thank you.
Thank you, Dr. Tepley, for that great overview. And now we're going to turn it over to Dr. Cook to talk about metastasis. Dr. Cook, you may be on mute still.
I was, thanks.
Okay. Great, thank you.
So thanks for having me today. So as mentioned, I'm going to talk about more of the signaling aspect of metastatic prostate cancer and what happens in the bone microenvironment. And so what I have on the first slide is fluorescent tissue staining of a bone biopsy from a prostate cancer patient. And the prostate cancer cells are identified by cytokeratin, which is a cell surface marker for epithelial cells. It's in green. And then the red is actually androgen receptor. The dark spots are actually bone that these tumor cells are surrounded by. You can see the androgen is actually really high in these cells. And I'll talk about that in detail next. So I'm trying to, so something has happened. Okay, there we go. So as mentioned, the American Cancer Society projected that nearly 29,000 people or men would die of prostate cancer in 2019 alone. And this is largely attributed to the development of bone metastases for reasons beyond our full understanding. Prostate cancer will most frequently spread to bone more than any other tissue site, where it can induce intense pain, risk of fractures, and spinal compression related to the bone-related changes that prostate cancer induces. And the current therapies have been mainly palliative, even though they have contributed some improvement in survival. And as the blue arrows are pointing out, you can see these kind of milky regions on the x-ray, and those are indicative of excess bone formation that's occurring due to prostate cancer in this patient's spine. So just to give you a little background about what happens in the bone tissue is actually very dynamic. Our skeleton is mainly for our support, and so it's constantly being repaired. So whenever there's a fracture or bone is worn, then osteoclasts are cells that will break down that worn bone, and then osteoblasts are the bone building cells that will replace that bone. And so under those specific cues, you have these precursor cells that will form these giant cells known as the osteoclasts. They will resorb any fractured bone or degrade it to get rid of it. And then in the process, growth factors that are stored in bone are released into that environment, and they will recruit these cells that will become the bone-forming cells that will replace that worn bone. And this is considered a couple process. So for the amount of bone that's degraded, you will have that amount of bone formed. In the scenario of a prostate cancer, when it's in the bone marrow, that prostate cancer can make its own particular factors that will also induce bone degradation. And so you will get these regions of excess bone degradation. And then in that process, again, you have release of these growth factors that the prostate cancer can then utilize to grow. And that's been characterized as a vicious cycle of growth, where you have constant stimulation of bone breakdown and then release of these factors that can then feed the cancer cells. A hallmark of prostate cancer, specifically in bone, though, is that it will also induce excessive bone formation. And so this bone that's formed in response to prostate cancer is actually very weak and brittle, and is the major contributor to the increased risk of fractures and pain that these patients will experience. And so a large role of my lab is trying to understand these individual mechanisms and how we can target those systems to prevent prostate cancer growth in bone, and also this cancer-induced bone disease. Now, as Dr. Tepley mentioned, some of the approved therapies, such as bisphosphonates, will target bone degradation, and also anti-rank ligand or denosumab, which will also target the fusion and formation of these cells that will break down bone. And those are key to preventing the bone osteolysis or bone breakdown. Also, as mentioned, radium-223 is a radioisotope, is very similar to calcium. So it will bind to calcium, and then it can actually emit alpha particles that can target the cancer cells. And then last, as mentioned, Sipuleucel T is actually geared at targeting or activating cytotoxic T cells that can also suppress tumor growth. But next I want to talk about where else can we go with what we know about the molecular happenings of the bone microenvironment. And so one of the things that we're still trying to understand is why we see excessive bone formation in these patients with bone metastases. And one of our key understandings is that androgens actually will help build bone. And so some things that we can think about is combination of androgen deprivation therapy to target bone formation, combined with some of our previously approved therapies that will target bone breakdown, like bisphosphonates and anti-rank ligand. There are also some approaches looking at combining chemotherapies. Guanidine is one of them that has been linked to bisphosphonates, so that it will be targeted to the bone area and be taken up by osteoclast during bone degradation, where it will kill the resorbing osteoclast and then also target the tumor. Another area of interest is in DNA repair mechanisms. And so one way that tumors acquire drug resistance is their ability to evade cell death in response to stress that will tear apart their DNA. And so PARP1 is actually an enzyme that will repair damaged DNA. And so there are some studies where we're looking at targeting PARP inhibition. And also PARP can regulate androgen receptor expression and signaling. And so you have kind of this dual targeting where you could target this DNA repair mechanism, but then also target androgen at the same time. And then, as mentioned, a hot area has been in immunotherapy. And unfortunately, the more commonly known ones, such as checkpoint blockade inhibitors, have been pretty unsuccessful for prostate cancer patients. Again, we mentioned Sipuleucel 2, which targets the cytotoxic T cells. But a large reservoir of immune cells in the bone marrow are these myeloid-derived cells. And so myeloid-derived suppressor cells are cells that can actually target the cytotoxic killing that would be determined by the T cells. And so a thing to think about is actually targeting these myeloid-derived suppressor cells in combination with our current checkpoint blockade, which would activate the T cells, but then also target these myeloid-derived suppressor cells that are inhibiting their activity. And then some things that are not currently in trial, but we're kind of considering on the research side, is tumor dormancy, where you have these cells that will disseminate into the bone, and then they will just sit there resting, not dividing for years. And then at some point they become active and begin growing and then inducing changes in the bone. And so we're trying to understand how we can target these cells so that they are vulnerable to chemotherapies or other therapies, but then also understand what determines their dormant state. And then also kind of upstream of a cell being able to get into the bone and interact with the bone cells, we want to understand how we can prevent those circulating tumor cells from actually being able to seed into the bone and grow into these lesions that are causing problems. So with that, that is my last slide. So I will turn it back over to Jill, and thank you for listening. And
I think, let me go up here.
And there we go.
There. Thank you, Dr. Cook. And thank you to our panel for providing a really comprehensive overview of prostate cancer from prevention to metastasis. And what I would like to do, I don't have any questions or comments yet from our audience. So I wanted to pose a question to the panel. From your perspective and your expertise, what do you think should be a research priority when we think about metastatic prostate cancer? And anyone can jump in and start.
So Jill, thank you for that question. And let me start it from a slightly different angle from the community perspective. And so as we have this great information that has been presented by Dr. Molesky, Dr. Tepley, and Dr. Cook, oftentimes this information is much too technical for our lay public. And so one of the things that we have done here locally is created a group called Pivot, which is patient and investigator voices organizing together. So developing a way that providers, researchers, survivors, and co-survivors can sit and watch a presentation like this and be able to break it down so that individuals, I happen to have someone here with me and watching this presentation and helping to be able to help the layperson understand the technical aspects of what's being presented, because all of it is great information. But if individuals who are receiving therapy or wanting to know about clinical trials or wanting to know about treatment opportunities, if they don't understand it, then we're not really reaching the audience that we need. So absolutely, prevention to metastasis is absolutely necessary conversation, but we also have to make sure that that conversation is easily understood by our target audience.
Thank you, Broderick.
And so I can sort of give my perspective about some of the priorities. And so you heard me speak particularly about some of the management options for patients that have very advanced castration-resistant prostate cancer. And typically, that's our therapies are developed, and a lot of our research is focused in that disease state. I think that one of the main things we've seen that have really shifted our survival for this disease is actually not focusing on that state, but actually identifying some of these very effective treatments and identifying the highest risk patients to use early on. A couple of the trials that have demonstrated by far, I think, sort of been the most practice changing have been those that have been able to identify patients when they're first starting androgen deprivation therapy and identifying those where it's worth it to use some of these drugs that have either higher risk or higher toxicity. Then what we find in the results from that is that in using effect in the right patients, they're much more effective if used early. And so I think that's one of the big challenges for the field is, appropriately identifying and using effective drugs very early on, while also not, going over treatment, understanding the significant toxicities. And so that's one of the priorities from my perspective.
Great. Thank you, Dr. Tepley. And thank you, Broderick.
And this is Sally. I just would also like to add that research and work on symptom management is highly important if we're going to maintain quality of life for men, and also looking at the impact of the cancer and its treatment on the family, on partners, and the financial impact of cancer and its treatment.
Yeah, thank you. I think those are both also important areas for us to address from research perspective, because they certainly impact quality of life.
This is Leah. I would also like to add to all of those points, which I think are all very important points. From the research side, I think more collaboration with the clinicians would help, because from the research side, we get so focused on looking at these protein pathways and different cells, but we really need to understand what the clinicians are utilizing to treat the patient so that we can make sure our models and our systems are more clinically relevant. And I think that would really fast track us being able to identify new therapies and get those to patients quicker if we had more collaboration on that end.
I think that that's an excellent point, and I am wondering, we have a couple of questions from our audience, so I'm going to ask those to our panel. But before I do, I wanted to hear from the panel's perspective about that kind of collaboration. And as well, as Broderick had mentioned, the patient and community voice being a part of that. So how do you think we can really foster this kind of collaboration?
I'll speak to Broderick's point. Actually, there are initiatives in certain cities and where they will be focused on science communication. One thing that we did in Tampa at the Moffitt Cancer Center was Taste of Science. And so that was where we would kind of open these kind of things similar to this webinar to the general public, and then people could ask their questions. And then that's where we actually got a lot of good patient perspective, because there was always someone who had some type of experience with cancer in their family, and they could ask us questions as researchers, and then as some clinicians would come voicing their concerns and then asking us more about the science. But I think just things like this, Dr. Tepley and I are involved. We're at the same institution. And so just interactions with each other, to me, is what drives the collaboration.
I will echo what Dr. Cook has said in that I think the big piece of it is for us to be more intentional. As she mentioned, her and Dr. Tepley being in the same institution, we have similar scenarios here at the University of Kansas where we have researchers and clinicians in the same building, but don't often talk about what their different either research or clinical interventions are. And so the more often that we can be more intentional about having those conversations, and then also including the patient voice. Oftentimes the patient is the last person to be able to provide input if we will involve them early on. Because of their lived experiences, we might be able to get better data or different data to help us be able to provide more effective treatment plans.
Okay. I want to shift to addressing some of the questions from our audience. So the first question is, where will Part I hope I'm saying that correctly, Part I best be utilized at the end of the day, pre or post chemotherapy?
So I'll start by trying to answer that, and that's a real unknown right now. I mean, right now there are active clinical trials sort of through the spectrum of disease, but to my previous point, right now right now the focus is with patients with castration-resistant disease. In fact, I sort of have a clinical trial open here of even in biochemical setting without androgen deprivation therapy, whether or not that's going to be sort of an effective strategy. In general, I think for what we see with most of our therapies, that sort of earlier use is going to be more effective before there's more additional mutations, other clones that develop. But it's a real unknown right now, because right now there's really not great data showing efficacy in any particular group. So it's a good question.
Okay, thank you, Dr. Tepley. There's also a question about, and I'm going to read this is a comment and question. Because we see castration-resistant prostate cancer also often develop neuroendocrine differentiation and can often be detected early by monitoring serum chromogranin A levels, are there strategies being researched to consider slowing this development?
I will say there is a field in the prostate cancer field focusing on neuroendocrine research. I would say also a limitation of that is our model systems and our availability. We're utilizing cell lines and mouse models, and we have very few cell lines that are similar to neuroendocrine tumor. And so that's been a major hurdle on the scientific side as far as being able to research that particular type of prostate cancer. I do think another thing that's important for patients or just the audience is that contribution to some of these research programs or scientific contribution of their tissues helps us in these endeavors when we don't have these models and everything. It's kind of tough to talk about, but our research is moved by our access to patient samples in essence.
Sure, right. To follow up on that, could anyone on the panel talk about vitamin D, 3 issues, and monitoring vitamin D levels to optimize those? Is that something that's consistently done? And if not, should it be?
So I think it's an important part of maintaining bone health, and so we try to do that in our practice here to either monitor and replete vitamin D. So I think it's the development of weakening of bone is a significant problem on androgen deprivation therapy, and so I think that is important.
Okay, thank you. And
along with the vitamin D, this is Sally. Along with the vitamin D, maintaining adequate calcium intake and the resistive exercise for bone health.
Okay. And with that, have you seen any challenges in, or what challenges might be faced by patients in using resistance exercise?
Well, I think knowledge, education that it is important, what they are, ways you can get it. I mean, you can simply use body weight in resistance exercise. It doesn't take going to a gym and lifting weights and a lot of complicated equipment, but just simply understanding why it's important, the education piece, and then ways in which it can be accomplished at home at low expense.
Okay, thank you. I think that's really important because I think sometimes when we talk about exercise, there's an idea that needs to be done in a gym and requires money and an effort to get to a gym, when there's often times ways that we can accomplish that at home. The last question is about the length of hormone therapy. So when someone is on hormones and abiraterone, I'm not sure I said that correctly, plus 4 cycles of docetaxel chemo followed by surgery and post-op radiation. If this protocol is followed, how long should the hormone therapy continue?
Again, I don't know if we know the answer to that, but typically, if a patient to go along the lines of a paradigm of patients that receive, for instance, radiation therapy or any sort of definitive therapy where we sort of deliver curative intent treatments to all the known sites of disease, whether that's in more of an experimental protocol for patients that have multiple areas or the prostate itself. I think it makes sense to continue for typically we do a 2-year period after the completion of all of these treatments and then to stop. Most of the data for abiraterone in relatively early stage disease, which currently is scant, but from STAMPEDE trial, typically did 2 years. And so typically we would say sort of 2 years, but that's not known. Good question.
Okay, well, thank you for addressing that. And then I think there's a follow-up question. If the purpose of androgen therapy is to reduce testosterone levels, does very physical activity level work at cross purposes with reducing testosterone levels?
I don't believe so. That is not anything that I've heard.
Okay.
I don't know if some of the others of you have.
Well, we will follow up on that if anyone has any additional input, and I can send this particular attendee information.
So I guess my perspective on that is that sort of the pharmacologic effect of actually this androgen deprivation therapy is much more so than I think sort of any increase that may be through exercise. So I think I would doubt that it would be at cross purposes, and I think it's really essential in terms of otherwise maintaining muscle mass and preventing sort of a lot of the side effects of androgen deprivation therapy.
Well, thank you to the audience for participating today and for your great questions. And thank you again to our fantastic panel for sharing your time and your expertise today to talk about metastatic prostate cancer. We will follow up with a short evaluation, so please expect that in the next couple of days, and we will have the recording of this webinar available to share as well. So thank you again, and I hope everyone has a great day.